Hello, good evening, everybody. Welcome to the another edition of the Resident Smart Teaching Program. Today we have posterior urethral valve, which is being dealt by Dr. Anil Takwani, who is a reputed pediatric urologist, and Arun would be introducing him to you. We are trying to make this program more interactive. So I want all the residents to share this information among your fellow colleagues that this is going to be an interactive program, and we are planning to have a sort of a quiz at the end of the program about the same topic. We are trying that from today. We'll see whether we can do that, but certainly next time we would be able to do that. And this would be, the marks would be considered for your fellowship program at the end. When there is an international travel fellowship, we would take this marks as an average of that and give you credit hours which would be counted for your traveling fellowship. So I want you to disseminate this information among your residents so that we have more people participating with it. Over to Dr. Arun.
Sir, Dr. Rajiv Sood has joined, sir.
Yes.
Yeah. Yes.
Thank you, Dr. Arun. Welcome to this edition of Distant Learning Program. I am seeing Dr. Vinu Gopal also joining us. We are obliged, sir, that you are there amongst us today in the flagship program of Urology Society of India, that is under Indian School of Urology. This is the great movement, and you know that pediatric urology has been well covered last year in our all the activities of Indian School of Urology, and this is a great beginning. And Dr. Anil Takwani, who is the eminent pediatric urologist, he is today deliberating on posterior urethral valve. Now, the beauty of this program, as has been highlighted by Dr. Keshav Murthy, is that now this has we have added the quiz, we have added the benefits to the residents, so that the number is maximized, and the participation is in this kind of interactive program is more fruitful. And not only these objectives, but also the addition of rewards and awards which are inbuilt in this program now, in this program of Indian School of Urology, is a new chapter, a new phase to the whole program. And I'm sharing with you, we are now applying to the medical council for the credit points also, and the whole program is going for that. And we have already slated the program for the entire year, and we will be getting the credit points for each program, each participation. And I congratulate all of you, all of us, for this great milestone which has been achieved. So thank you again to one and all the council and office bearers of USI, all the active members and faculty, FISU, the faculty of Indian School of Urology, and also especially Dr. Anil Takwani today, who is taking the pains to for this beautifully crafted format for this distant learning program, and Dr. Arun Chawla, who is taking real pains to make this program successful and beneficial for the residents. Thank you very much, and I will hand over to Dr. Arun Chawla to start today's academic deliberations.
Thank you, sir. It's my privilege to introduce today's teacher, Dr. Anil Takwani, to the residents. Actually, he doesn't need a formal introduction. Interestingly, yesterday when I spoke to him, he specifically mentioned how humble and polite he is. He specifically mentioned that please don't talk too much about me. So I'll say only one thing, that in our urology, you need not be in teaching institution in a medical college to be a teacher. You can be a teacher if you are passionate. And this is example set by Dr. Anil Takwani. Pediatric urology is a subspecialty which is very close to his heart. And he has prospered in this field under the shadows of none other than teacher of teachers, Professor P. Venugopal. Both have been very active in the Euro Education Group in disseminating the web-based teaching on all the subjects, especially the pediatric urology. With PVG sir here, I don't know whether we can finish this subject in time, but we have a little constraint of time. Otherwise, I remember when we were students in Manipal, Venu sir used to come, and not even 1% of PVG sir has covered the PUL. And it used to go on for days and days and days, and then he will say, okay, next month when I come again, we'll discuss rest of the things. So he's a master in this field. His comments in the end probably will add a little more value to today's lecture by Anil Takwani. And Dr. Keshav has already told that this will be followed by a quiz, a 10-minute quiz competition. And he has already told how important it is for all the residents to participate in this quiz competition. With these words, over to you, Anil. Stage is yours.
Yeah, thank you very much, Dr. Chawla sir, for this very kind introduction, and thank you very much to USI and ISU. This is absolutely true that not being in the teaching institute, I'm always missing residents. But with the blessing of Professor Venugopal and participating again and again in a digital learning programs, now probably I have a large number of residents in my close group, and that is what really is very much matter to me. So once again, thank you very much, USI ISU, for this excellent initiative and equally excellent opportunity to me, the person who is not practicing otherwise into the teaching institute. So with that, I would like to share my screen. There should not be any problem. And definitely to begin with, I would like to say thank you to my mentor to join this program, and hopefully I will be able to satisfy not only the resident but my biggest mentor, Professor Venugopal sir. So just to introduce this subject, this is a post-urethral wall, and I have added the caption that is it a never-ending story? And it's absolutely true, because whenever we see this patient, we generally jump in because it's very easy to diagnose, and initial treatment is almost very easy for almost everyone. But subsequently, this patient is to be treated, followed and treated for a very long period of time, maybe adolescence or much more beyond that. So it's a never-ending story, and we will in next 1.5 hours we'll see that how exactly we have to do this. So we move into the what happened? Yeah. So the format for this program is that I have to speak, and I will try to incorporate certain quiz question which I have promised to Professor Anand Chawla as well as Dr. Keshav Murthy, our secretary. And so I need a couple of volunteers, resident, to take those questions to make the session more interactive. It will not take much time. So with sir, your permission, Keshav Murthy sir, can I have a couple of residents who can be unmute to answer the question, sir?
I think there'll be people. Arun will share with you the names of the people. Arun, you have the names of the people?
I'll do that, sir. I'll do that. Just give me 2 minutes.
Okay, fine. So let us start with the defining the PU wall. It's a congenital obstructing membranous folds within the lumen of posterior urethra, causing lower urine tract obstruction in fetus, which starts very much early in the utero. So this is the very popular statement of the Sir David Innes Williams, that the primary lesion is simple to treat, but the total care of a boy with PU wall is complicated undertaking. And here, actually, if I get a resident, I would like to know from them that what is the contribution of Sir David Innes Williams in the surgical management of wall ablation. Any resident? I think let us take this question to Sir Venugopal sir. You are master of history. So David Ince was the person who designed the hook, probably a kind of a hook which was almost similar or equal to the croquet hook, which can be introduced, 6-7 French hook, which can be introduced blindly and then pulled into the prostatic urethra, engaged with the valve, and then the valve was ablated, and which
then
was
it will be
modified.
taker.
Yes, sir.
It is not David in his limbs, it will be taker who introduced the hook.
No, Whitaker modified. Whitaker gave it insulating arms, leaving the just distal portion. Whitaker modified. So now, then it becomes popular as a Whitaker's loop. His contribution was to insulating most of the part, leaving the end part of the hook. Anyway, so it's a primitive tissue. The reason is that why it is never-ending story. That primitive tissue mature in an abnormal environment of high intraluminal pressure and organ distension. So it gives a universal injury in whole urinary tract. So today's our objectives will be the little bit look at the embryology and epidemiology, presentations of PU valve, antenatal and postnatal management, post-urethral valve, along with the secondary reflux, how to manage it, valve bladder syndrome, again, how to manage it, considering the never-ending story, long-term follow-up, and the prognostic indicators. So all these things I have tried to incorporate it in case scenarios. So before we go ahead, this is quick important facts related to the PU valves. The most common structural cause of urinary outflow obstruction in pediatric practice, 1.6 to 2.1. This is, I'm talking about the lower urinary tract outflow obstruction. So 1.6 to 2.1 in every 10,000 male birth. That can be the latest European as well as the American figures. The most common treatment for valves identified in utero is still fetal termination. The children that survive the over 30 to 40% develops the ESRD, and changes in the renal development may begin to occur as early as 14 weeks of gestation. So the need is that we need to identify this condition just about that time or prior to that. So majority of intervention which are done later than this, which are not much useful, we can change the paradigm, we can bring the shift into the management. So procedure for fetal bladder decompression remains technically difficult with limited proven benefits. So these are the major facts related to the PU valves. And this is some short history as Professor Venugopal sir is there. So I'll quickly go through that. Valves like leaflets was recognized by Morgagni in 17th century, and Langenbeck further confirmed it in 18th century. But Young in 1999 described the first endoscopic diagnosis of urethral obstruction and coined the terminology PU valves. And Rendell in 1920 carried out the first endoscopic valve resection. And more or less, there are little bit of sophistications are there because of instrument miniaturization of instruments and the gadgets. But most of the things still we are following of a Young and the Rendell's contribution in the subsequent years. So this is a quiz question for resident. If you identify the resident, one can be unmute himself.
Yeah, give me 1 minute.
Yes,
Suraj, Milap, and Dr. Ramiredi, please unmute yourself and keep your video on.
it will be very interesting, sir.
Yeah.
Keyhole deformity, sir.
What is the? It is keyhole deformity. Who is this person? Can you tell you my name?
Suraj.
Your name? Suraj from?
Suraj.
You are from?
KMC Manipal, sir.
Okay, excellent, great. So your answer is true. Just describe how you can say it is a keyhole. Can you describe this structure? What is this? Are you seeing me? My video? What is this?
Yes, sir. Yes, sir. Yes, sir.
What is this? Right. And what otherwise tell me what is this? So it is a distended and thick wall bladder, right? And then there is some elevation of bladder neck, and then there is a dilated and elongated posterior urethra. So all this together gives a impression of a keyhole, and that's why keyhole sign is there. Though it is not absolutely pathognomic of the posterior valve, but most of the posterior valve we can pick up with this kind of a finding into the sonography. Now, second question to me for the resident is that how you define the thick wall bladder? Anyone? Very creamy question. Very. If you answer it, I will give you the prize. How will you define the thick wall bladder? Yeah.
We have wall thickness. If the
Uh,
bladder
we-
is
Plus,
extended,
first of all, you pronounce your name and your institute.
Ashutosh Kumar Tiwari from ICCNR Kolkata. If the bladder is distended, then the thickness should be more than 3 millimeters. If it is
Okay.
not, and it should be more than 5 millimeters.
Okay, perfect. Who is this person who has answered this question?
Ashutosh Kumar Tiwari from
Okay. So your answer is perfect, and you are winning a prize from me, and I will reveal at the end what you have win. So if it is a thick wall bladder defined as that when it's collapsed, it is 5 millimeter or more, and when it is distended, it is 3 millimeter and more. Then it is qualified as a thick wall bladder. So we move to this further case that this particular patient's parents referred to you for counseling. This is very frequently we see in our practice. There were, again, I am repeating this bilateral hydronephrosis, renal cortical echoes normal. Listen this properly. Bladder distended, amniotic fluid adequate. Again, very important. So questions posed to us that how will you counsel and what will be your follow-up protocol? So this should be our answer, that we'll inform the parents regarding the possibility of PU valves. Along with that, we have to consider the DDs in our mind, that prune belly syndrome, urethral atresia, and bilateral VR, massive VR, with and maybe sometimes bilateral obstructed megaureter. And these DDs should be kept in the mind, as amniotic fluid is adequate and renal echoes are normal. We don't have a dysplastic kidneys there. So at present, nothing much to worry. We simply reassure these parents, and we have to do a follow-up USG in the third trimester, a little more frequently, and the delivery should be done in a hospital setup. That is very much important in the area where I'm practicing. So this child born without problem. Only complaint was a poor urinary stream when the child voided first time, and the bladder was palpable. And as parents were knowing, and the gynecologist was knowing, this patient was referred immediately to the urologist. So the questions posed are how soon one should start treatment, and what investigations will you advise, right? So these are the very important questions for you for exam purpose or your practical exam purpose. So the management of these children starts immediately after birth. So what we need to do is that we need to put a 5 to 6 French feeding tube to start draining the bladder, which is distended. And sometimes we may not be able to do it with the straight feeding tube. So we need to use this Cody tip tube. But our preference should be of a bulbless tube. Means the bulb catheters are not preferred. The reason bulb can lead to the spasm, very easily spasm of these trabeculated and inflamed bladders, and that can further make this urinary drainage from the ureter difficult. Sometimes we need to take help of the Scout film to see that we are not coiling. The tube is not coiling into the dilated posterior urethra and this elevated bladder neck. So immediately sample for urine routine and culture need to be collected. IV line should be secured, as these childs are prone for dehydration. So we have to give some hydration as well as antibiotics. The blood sample drawn after the 48 hours. So if we draw the blood before 48 hours, any resident, what is the problem if we draw the blood before 48 hours?
Amit, Rajkumar Sharma, you can unmute yourself. Amit and Rajkumar.
Hello.
If we draw the blood before 48 hours, what is the problem?
Hello.
Yeah.
Am I audible?
Yeah.
Sir, good evening. Myself is Dr. Amit Sharma from SCB Medical College, Cuttack, sir.
Good.
If we withdraw before 48 hours, this reading will be false, as the maternal removal of creatinine will be there, and
it will reflect the maternal values. So maternal values start disappearing after the 48 hours maternal blood, right, which is transferred through the placenta. So your answer is right. And so even if we take that sample, which we have to read with the caution, and so 48 hours and 70 to 72 hour samples are very important. We have to look at the serum creatinine, sodium, potassium, and the chloride. And we have to be very watchful. We have to very much watchful, or we have to take help of pediatricians or pediatric nephrologists, depends on our institute. Look for the signs of dehydration and acidosis. So this is another question to the resident, that how you recognize the acidosis in neonate? What could be the manifestation in a first month of the, because they can develop acidosis anytime, even if after the treatment. What kind of acidosis is this? It is a metabolic acidosis, right? A kind of a metabolic acidosis. And how you will recognize this from the symptoms? Why I'm telling you is that recently, before say 1 month, I did a Ferguson 1.5 months before. And when in the first follow-up, the child was doing well. He gained the 100 gram of the weight. But when I was planning to travel to the Chennai, at that time, second time when they came with the nausea, vomiting, a kind of dehydration, irritable child, excessively crying, not taking feed, and some weight loss, right? So these are the, and maybe sometimes some sepsis. So you have to look for these dehydration and acidosis. And then comes to the other investigations that we have to advise for the sonography within first 24 or 48 hours, and the kidneys to be seen for the cortical echogenicity, CM differentiation, degree of hydronephrosis. We have to look at the dilatation of ureters, bladder for distension, thickness, presence of diverticula, high bladder neck with hyperplasia, posterior urethral dilatation, and maybe we can measure the length, urinoma, urinary ascites, and other abnormalities. And in the micturating cystoelastography, we have to see for conditions of the bladder and diverticular. Can someone help me for this background noise? Yeah, okay, perfect. So this is the what we do in avoiding cystoelastography, right? What we try to see is the bladder with the diverticuli, reflux, if at all there, unilateral or bilateral, and degree of the reflux, bladder neck elevation or hypertrophy, dilatation and length of the posterior urethra. And this is very important. This is abrupt funneling, which confirms the almost wall and its location. And there is a kind of a membrane sort of impression we get in couple of cases. If you see this picture, making little carefully, you can see that abrupt termination and funneling, and there can be, you can predict the location of the wall there. So this is the another question. What kind of a complication of MCU is there in this particular picture? Amit, you can unmute. What kind of a complication is seen in this MCU?
Sir, abdomen is urinary ascites, sir.
Okay, so one possibility is urinary ascites. There is already some bladder perforation, right? At the time of during the in utero or birth, and some contrast is leaked during the MCU. But what else it can be? It can be bladder rupture, which is induced by the, can be sometime, very rarely, but can be induced by the MCU, right? And for that, I want to know the bladder capacity in newborn child. Amit, can you tell me?
Cos formula is there, sir.
Tell me.
Age in years +2 into 30.
Here it is neonate.
Sir, neonate is
up to age, 1 year. Up to 1 year. Yeah.
Age into 2.5 plus 38, sir. It's infants.
So what do you think roughly about what could be the capacity of the neonatal bladder?
50 ml approximately, sir.
So I don't know from where you have find out this equation, but what is this? This is a bladder perforation, which I have come across once only in my 21 years of practice at the single place, and following the infusion of saline with the force and beyond capacity. And to my mind, the average capacity is around 30 cc or 25 to 30 cc, and this is the This is the rupture of bladder due to the overdistension. Estimated bladder capacity we have to give to the radiologist if we are not accompanying with the patient, right? So in neonate till the infant's age, means up to 1 month to 1 year, less than 1 month and 1 month to 1 year, it is 7 into the weight. So suppose if it's a 3 kg child, right, at the 1 or 2 days of the age, then 7 into 3, so it roughly comes about 21 cc. So what I instruct to the radiologists, they don't infuse more than 25 to 30 cc of saline, and also you have to see that, and we have to put a catheter for them. We cannot rely on them. They cannot have aseptic precautions. So we have to insert the 5 or 6 on already. Most of the time our feeding tube is there in a case which is delivered under our observation or with our knowledge, right? But suppose the patient has come from the other place, then also our first treatment, as we discussed, is putting the feeding tube. So most of the time it is we put the feeding tube, so it should be put in a aseptic precautions, water soluble contrast, and slow filling with the gravity under fluoroscopy control. And complications of this procedure are dysuria, introduction of infection, hematuria, retention of urine later on, and rare rupture. So, and very important learning point is that already we have a little bit discussed is the look for the dehydration, acidosis, and sepsis if you are treating alone. And maybe the pediatrician is coming only for a couple of time to see this child. So post dehydration, we can understand it is a post-obstructive diuresis as well as tubular dysfunction on these patients. So they are pouring a lot of water. Acidosis is kidney tubules do not absorb SCO3. So if you look at the blood level, the SCO3 will be less in this kind of patient, and then decreased pH, which is there can be a decrease in serum SCO3. This is the normal value in neonate, 22 to 26 milliequivalent. I know it's very difficult to remember, but this is very important. Whenever we advise electrolytes just done, and there can be an initial spell of hyponatremia also because of hypoaldosteronism sort of a condition. There can be some initial spell of hyponatremia, and along with the acidosis, there can be some element of hyperkalemia. So all these things, whenever we advise electrolytes, we have to look carefully for this. Now, coming to the once this patient was stabilized very quickly within 2 to 3 days, we get MCU, we get all this biochemical, this renal serum creatinine stabilized, and then electrolytes were perfectly all right. Patient was not dehydration, so we can go ahead with this surgical treatment. And the standard treatment for the any proven valve is the valve ablation. What we want to achieve is the obstruction-free voiding, and second thing is that a good bladder recycling, so bladder do not have a further insult on it. So in this patient, we can go ahead with the primary valve incision and direct vision using an infant erythrocystoscope, and somebody even use resectoscope. Both have put in the picture. Resectoscopes are generally of a 9.5 French. Integrated erythrocystoscope with the offset vision, they are generally 7 or 7.5 French. What I have is a 7.5, 8.5 French, and then it is individual choice. Somebody use a hook electrode, or you can use a Bugbee, and according to the configuration of the valve, you can incise the valve as 4, 8, and 12, or 5, 7, and 12. To my point of view, 12 o'clock ablation is very much crucial and very much important. And after 3 to 4 days of catheterization, urethra is capacious enough most of the cases. If it's no preterm birth, then admit the endoscope without trouble. So we have to be very sure that we are putting this endoscope with utmost gentle and comfort. Otherwise, keep the feeding tube for a little longer. It will give you a passive dilatation, and then you can finish this procedure. But there are certain there are indications which we'll discuss later on. So before we do this procedure, we have to look at the clinical condition: no acidosis, no sepsis. Patient should not be dehydrated, and we have a little bit talk about this Crockett hook, right? That was the initially used in 1970, 1980. Sir is knowing very much. Even Dr. Chawla must be used, and then Whitaker insulating hook. These are the 6, 7 French, do not require larger instrument, and this is not under vision procedures. So here you can see this is the almost type 1 shot of a classical PU valve, where you can see it no, it is mainly I have demonstrated ablated at the 4, 8 and the 12 o'clock, and it should, but we should not be very much, it should be very gentle sort of fulguration, because these are the very thin membranes, avascular membranes, and very not required a vigorous resection, or you can say vigorous ablation, burning. Otherwise, there can be stricture. Recently, we have a publication into the Journal of Pediatric Urology from SGPGA from Professor Ansari. They have their own cases as well as couple of cases coming from outside, and how difficult to treat these strictures if then they develop into the posterior urethra, or you can say bulbomembranous urethra, and these are very difficult. This is the picture courtesy from the Professor Margit Fish, and success rates are only 70%. So you can understand this, these children suffers a lot if they develop a stricture, and this is the similar findings are there into the paper which is published from the SGPGA by Professor Ansari. So quickly we go through this theoretical part of PU wall classification, which was this was published in the 1999, proposed by the Young, and still we talk about this type of the walls even in the today's discussion. This is the something about the type 2. This described as a folds extending from the verumontanum to the bladder neck, and these are not obstructing folds, so that these are the condition considered as a normal. But our focus is on the type 1. Type 1 are mucosal folds which are extending from the either side of the verumontanum to distally towards the membranous, or you can the sphincteric urethra. They abruptly end at the just proximal to the sphincteric urethra, and fuse anteriorly to form the septum, or you can say membrane. And this is believed to be result of abnormal insertion of the most distal aspect of the Wolffian duct during the bladder development. If the Wolffian duct attach itself at the means terminate at the normal, then there will be a verumontanum at the normal place, and there will be ejacular ducts seen, and then the prostatic utricle. But if it is push it little more anteriorly, there it will take the mucosal folds along with it, and little more distally towards the membranous urethra, which is considered as a membranous walls of the type 1. And this is something about the type 3 walls, and this is just like a annular ring or diaphragm at the just distal to the verumontanum into the membranous urethra part, or sometime even a little more distal, it can be seen. And this is a result of incomplete dissolution of the urogenital membrane, right? So there is a failure of proper canalization between the anterior and posterior urethra, which can give rise to this type 3 valves. So this is the sagittal plane, which can very much explain us. This is the elevated bladder neck. These are the normal folds, superficial. This is the verumontanum, and there you can see this is the on either side the membranous folds are extending, and then it fuse anteriorly and forms the type 1 sort of wall. And here you can see it is an annular ring with this aperture into the center. But overall is that this is what it can be, that it is a hypertrophy of urethral folds. That was earlier theory. Then it can be a cloacal remnants cause the appearance of the valves after the division of urogenital membrane. I'm not going to go in detail. According to the Lowsley, based on the autopsy study and abnormal development of the Wolffian ducts, which we have discussed, and this terminology which is came in last 20 years, means 2 decades before, that it is a congenital obstructing. It's a COPUM. COPUM means congenital obstructing posterior urethral membranes. They said that in autopsy findings, they've seen this is when it is undisturbed, this is more or less same as a obstructing membrane into the prostatic in the posterior urethra. But they says that when we put a feeding tube, whether into any tube, antenatally or postnatally, it gives a aperture there or some disruption into this membrane, and maybe then we classify as the type 1 or type 3. That is what my understanding. And so this is something which we covered into the first case based discussion. I hope this is useful, and based on this, we will be having a couple of questions which we will take later on. So I'm quickly moving to the second scenario, which is very much possible with the PU valve, that there can be a reflux, unilateral, bilateral massive reflux. So it can be this case presented to me on second day following normal birth, poor stream with palpable bladder, no other problems. Creatinine was 0.8 milligram percentage. Sonography was suggestive of bilateral moderate gross hydronephrosis, right side kidney seven differentiation poor, increase echo, serum electrolytes normal. So here you can see this. There you can see this distended thick wall bladder. Then and you can see both the ureters are quite significantly dilated. So always insist, not for this kind of a cases, but any case, when you send the patients for sonography, insist your sonologist to look at the bladder level with the full bladder to see for any ureteric dilatation, which you can see in the juxtavesical area. And then you can see bilateral kidneys are grossly hydroureteronephrotic. And this is the MCU picture, which was done on third or fourth day. There you can see abrupt end. There you can see some membranous a fold-like structure, and then the normal bulbar and penile urethra. Bladder is trabeculated and almost looks like of a neurogenic bladder, and then you can see massive reflux on both the side. So what some details about the reflux that present in the almost 50% of patients. It can be bilateral in another 50% of patients. So it can be there in 50%, and out of those 50% can have a bilateral. And post-treatment, VR can still persist in almost 20% of cases. Unilateral reflux, it was believed, and it is still occasional, means believed, that associated with the better prognosis due to the presence of pop-up valve mechanism. If the time permit, we will come to this issue later. Higher incidence observed with an early age of presentations and persistence of VR could be because of residual valve, altered bladder dynamics, and para-aortic diverticulum. So how to manage this case? So we have to not to worry about the reflux at this juncture. Fulgurate the valve with a pediatric scope, as we discussed. Post-operative, I tend to start oxybutynin empirically in this kind of patients in a dose of 0.1 milligram per kg once or twice, and continue with the antibiotics for 10 days to cover the treatment period, and then prophylaxis to be continued. And if post-void residuals are a little bit there, and some elevation is seen in the MCU or during the valve fulguration, then we can think about the starting tamsulosin. So both are having now a number of publications in the literature and supporting this treatment. But the next question set is that to all I'm posing is what about the follow-up USG and renal scan, when it should be done? When will you consider follow-up MCU? Do you perform cystoscopy? This is the question comes to us, that post-treatment in all, and when? And what about the circumcision? Now, these are the responses that post-perguration in 2 to 3 days, we can get the USG and serum creatine electrolytes. Maybe we may not get USG if you are if the child is voiding very well as bladder is clinically empty, but otherwise we have to get the serum creatine and electrolytes. Monthly urine analysis for a couple of months with culture. We have to specifically look for the weight, whether the child is really getting, the neonate or infant is getting the weight or not. In the renal biochemistry, as we discussed, at 3 months, we have to definitely get the USG of KUB to see the dilatation of PC system in ureters, which we have seen in this patient. And we have to look at very carefully, if possible, residual urine within the bladder. And repeat MCU, that is what I practice. And maybe you have to answer in the exams that 3 months or 2 to 3 months for any residual VAR or any changes in the bladder subsequent to the valve ablation. And cystoscopy, I perform only if MCUG shows persistent or significant obstructive changes to me. And DMSA renal scan or diuretic renal scan, I plan 3 months for cortical function and quantification of scars. So in this patient, you can see this follow-up for USG seems little better. The dilatation significantly reduced. Some cortical thickness is seen, and there are no dysplasia.
वो Zoom meeting देख रहा था.
Oh, please back down. Yeah. Oh, okay, fine. Thank you. So, and this is the MCU which is done at 3 months. You can see that there is no any findings suggestive of obstruction in the form of residual wall or stricture formation, and then significantly the reflux reduced, and definitely the burden of the reflux was much more on the left side, and that can be depicted here in the DMSA renal scan. These kidneys bit hypoplastic, or you can say dysplastic, but uptake is very much uniform, and the right is almost practically normal. So, and the creatinine at that time is 0.6 milligram now, electrolytes normals, urine no infection. So this is how we should need to follow this patient. And now next question set is that now what? 3 months finished, child is doing well. Will you continue medications? Which? Check cystoscopy. What about the circumcision in these children? And how long will you follow this patient? So this should be our response. I, in my practice, do prophylactic circumcision. Many of the consultants or teachers, they don't do routine circumcision. If the child comes with a recurrent urinary tract infections, having a reflux along in a treated case of wall ablation, they, after trying couple of time treating with the antibiotic prophylaxis, they add circumcision. But the overall evidence is in favor of circumcision, and I do believe even in the prophylactic circumcision when I have this kind of a condition. And then periodic renal function, continue antibiotic prophylaxis. It depends on the which kind of a family you are treating, but definitely answer is continuing. Renal functions, electrolytes, full blood count, urine culture, test for proteinuria. These are coming repeatedly there, but these are the only important things. USG for revolting upper tract, and also PVR. Never forget to do PVR. And fluid intake output once the child grow, reaching to the toilet training. You have to see for the fluid intake and the output for 2 to 3 days. Keep this chart even in the normally doing child. Make a habit that you have some, after once the toilet training is reached, we can have some insight, because they don't generally come with the symptoms. We have to find out what the wrong is going on without obvious symptoms or without obvious findings into the sonography. So renal scan once at 2 years, further depends on the sonography. Video urodynamics at the age of 4 or 5, or depends on the how the patient presents, or patient is having a non-invasive sort of details in the form of post-void residue in the sonography, uroflowmetry, and the water intake and output, and nighttime output, early morning output after the whole night. So all these are non-invasive sort of details which you can say, and based on that you can plan your urodynamic based on the presentations, and a follow-up should be at least for 15 years for pediatric urologist, and then adolescence reference. So in this patient, if you see, this MCU is not that great because of child non-compression, no cooperation, but you can see that reflux is almost disappeared, and there is no obstruction in the wall, in the urethra. And this was the sonography at the 3 month. You can see 3 year, you can see significant reduction in the dilatation of the PC system and the ureter, and there is no significant residual urine. And this is all can be achieved with the complete destruction of the wall, careful attention to the bladder dynamics. We have to address the hypercontractility with the empirical maybe treatment, and the low compliance, use of anticholinergic, judicious use of anticholinergic in initial months of the life, then the careful attention to the fluid intake and the output, and time voiding, double voiding if required, nighttime voiding as well as nighttime catheter drainage, and avoid UTI. Maybe with the antibiotic prophylaxis, adding the circumcision, we can achieve this kind of outcome. And then this is the child of a radiologist who is practicing just in my neighborhood. So we have a liberty to get his repeated sonography. So I just advise to get a sonography. He's now 14 years. And this is mainly for this discussion purpose. You can see that the hydronephrosis has almost disappeared, right? And we don't need to do MCU. The child is doing perfectly well. So we do periodic these investigations. We look for the height, weight, blood pressure, and then urine routine micro and at times the culture. So you can see that this is how the most of the patients can be treated reflux with the PUJ. These valve patients. The focus of management should be centered on the bladder. So safe storage, and obstruction free or a proper pressure voiding are the crucial thing to treat all these things, and almost no to the ureter reimplantation. We should be having a very least threshold or almost no to the ureter reimplantation. I have never ever done in my 21-year practice. So this is again a little bit of interaction with the resident. What terminology you use for this condition, which is related to the PU wall. Here you have a MCU. Here you have a DMS scan. So any resident?
Yeah, Milap, Amit Tiwari, please unmute yourself.
Sir, it's VCUD, sir.
What is this?
VURD.
VURD. What is the complete
Vesico-ureteric reflex dysplasia.
Vesico-ureteric
reflex dysplasia.
So you are right. It's a VURD. And now this is for Amit, not for you, for others. When you unmute, please see that there is no background noises. So there are in literature, something is about the pop-up mechanism, which is challenged over a time. We will not put too much of time for that, but just for the brushing up our knowledge, one of you unmute yourself and tell me which are these 3 or 4 pop-up mechanisms. Yeah, come on. Shruti is there, sir. Arun Chawla, sir. Shruti is there from Manipal Institute.
Yes, she's there, sir.
Yes.
Yeah,
Yes.
so she is very smart, and I always find out the girl urologist.
Yes,
So
sir.
yeah, so it is your now turn.
So the first pop-up mechanism is VUR, sir. That is one
Okay.
first pop-up.
VURD. Okay, VURD. One side.
VURD, sir.
So one side there is a
Unilateral,
massive.
yes.
Yeah. Okay.
Unilateral VURD, which is a pop-off mechanism to preserve the contralateral system. So that is
Okay.
one.
Next.
So second is a bladder diverticula, sir. That is
Okay.
one of the.
Yeah, good. Excellent. Third. There can be some urinoma and urinary ascites, right? Urinoma because of corneal cell rupture, which is considered as a pop-up sort of mechanism, which is also under controversy. You can read that beautiful controversy in the Campbell. I will not go into detail. Certain people say that it compresses the pelvic cell system, so no more a good thing. And several investigators or the writers, they says that it is a pop-up mechanism. And sometimes there is this urinoma, if it is a massive, it transmutes into the peritoneum and it can give you the urinary ascites, which you can identify with the help of sonography, or sometimes there can be a minute blood rupture and there can be urinary ascites which go into the peritoneum. So these are the 4 pop-up mechanism. Excellent, Shruti. So we move to the third topic, which is very controversial as well as very much important, but that is intervention of the fetus. Intervention of the fetus with antenatal lower urinary tract obstruction is controversial. The reasons are the accurate diagnosis with current technology is difficult. We cannot say 100% this is only a PU wall. Natural history of each conditions, prune belly syndrome, urethral atresia, PU wall, causing this antenatal hydronephrosis because of LUTO is variable and has not been fully elucidated. And lack of data regarding the success and complications of the intervention in cases of PUV, it makes it controversial. Now, what are the options when patient approach to us? One we discussed already. This is another one is the intrauterine intervention. Second is a shunt or fetal cystoscopy. These are the interventions. One can take mother for elective LSCS. We'll discuss this also a little bit. And the medical termination of pregnancy, which is now Parliament passed that it can be done up to the 24 weeks from the 20 for the certain specific conditions or medical conditions. So this is the third case, which is I am introducing severe oligo. This fetus was having a severe oligohydramnios, bilateral severe hydronephrosis. Here you can see this is a bladder, this is the right kidney, this is the left kidney, and normal renal, and then isolate. This is what we need to be sure that this is an isolated malformation, absence of cystic dysplasia, which can be picked up in the sonography. A normal, there should be normal karyotyping, and this is another criteria is the normal renal function, which can be determined by the urinary estimate of the certain electrolytes. So 2 to 3 separate samples in the 48 hours apart, if the values are increasing, then this is not the good sign to go for an intervention. So these are the values. I'm not going to go in detail. This is all I've written. It can be very difficult to remember all these things, but these are the normal values: protein, beta-2 microglobulin, sodium, chloride, calcium, and osmolality. All these things need to be measured, and 2 to 3 samples in the interval of 24 to 48 hours to be done. And then there are two interventions. One is vasoamniotic shunting. Here you can see that this is in the progress. It is under the sonography guidance, and there you can see that the guide wire is to be inserted under the sonography, puncture through the uterus to the bladder, then the guide wire, and then this pigtail catheter is pushing with the help of the pusher. And the procedure appears very almost easy, but it's not like that. These are the picture courtesy from Professor Mohammed Isa from the Egypt. We had in 2014 a symposium with him. What are the benefits? It improves survival in worst cases by improving the pulmonary function. This is the it's a non-controversial thing, but maybe advantageous for renal function in couple of cases, very few cases, particularly in patients with the adverse urine parameters. But high complications rate, up to the 40% in vasoamniotic shunt in the migration, obstruction, displacement. And another intervention is a fetal cystoscopy. Fetal cystoscopy done is with the 1 millimeter telescope, and then it is introduced again transuterus into the bladder, and then integrate. We have to go into the urethra, find out the wall, and then ablate it. It also appears nowadays very much of procedure which is there. I have seen in the CHOP certain centers into the USA. I witnessed there, and I have inquired even in the several centers in the India also. It is vasoamniotic shunt is done specifically in the south side of India. A couple of centers are there. And what are the complications with the fetal cystoscopy is the fistula formation, and then almost recurrence of LU2 in 10% of cases. And adding to that, the preterm delivery and death after the birth. So this is something about the Pluto trial. Can you give me a full form of Pluto? Anyone, any resident? So P for percutaneous vasoamniotic shunting. It is P, and conservative management. So these are the two arms where compared each other. That is LUTO. So percutaneous vasoamniotic shunting versus conservative management for LUTO. That is a Pluto trial. This is the only one randomized trial available, which was terminated prematurely for certain specific reason because of paucity of data, poor recruitment, and pregnancy termination, and also matter complications to the mother. Only 12 live births in each group, improved survival in shunted those who got the vasoamniotic shunt group for 28 days only, but overall survival was same, and high mortality because of pulmonary hypoplasia and greater risk of pregnancy loss and maternal complications. And because of that, we don't have a further any kind of a randomized studies to quote about the fetal intervention. So we move to the another scenario, which is little worse. There you can see these keyhole sign, but the kidneys are not much hydronephrotic, having a dysplastic changes, increased echogenicities, loss of corticomedullary differentiation. So in this kind of a condition, we get a question that will you consider medical termination of pregnancy? And if you do not, then how will you cannot because of certain reason, how will you counsel this family? So this is worsening scenario. And now, as we know, this medical termination of pregnancy is allowed till the 24 weeks. This kind of a fetus becomes very big liability, and specifically those who are not having a resources for them and for that particular child, the life becomes a hell. So if they are within the 24 weeks, we can definitely advise for medical termination of pregnancy in this particular scenario, the scenario which I have described. The post family has, if it is not possible because of the 24 weeks of fast, or they don't wish, or because of any reason, then post-delivery chances of this child, we have to explain them into the CKD are very high and may need the transplant later on. Conservative management of CKD requires strict diet and cooperation from the parents. Children find it difficult to stay with the diet and the water intake, specifically going to school. Availability of pediatric nephrologists is of great help in this condition. But all I'm not going to go in detail. One can take mother for elective LSCS in these circumstances if more than 30 weeks in a tertiary care center with availability of PICU, neonatologist, pediatric nephrologist support, and we have to not forget use of injection betamethasone, which can help in the reducing the problem with the hypoplasia of pulmonary hypoplasia. This is, I'm not going to go in detail, just put this slide. It is very exhaustive slide, but Society Fetal Urology, SFU, staged the fetal lower unit tract obstruction to guide that which patient should, which fetus to be taken for the intervention, which should not be. So 3 major criteria. One is amniotic fluid, second is the normal kidney echogenicity or abnormal echogenicity, and third is the favorable urinary biochemistry. If these 3 things are excellent, then as we discussed in the first case, prenatal surveillance is recommended with the reassurance, right? And we can go ahead with the normal delivery. And second stage LUTO is the oligohydramnios, but still not anhydramnios. And then the absent renal cortical cyst and obvious dysplasia, but there is some loss of corticomedullary differentiation, but still favorable fetal urinary chemistry. In these are the patients where we can go, we can think about the vesicoamniotic stenting if they are wish, and fetal cystoscopy if indicated to prevent pulmonary hypoplasia and early renal failure. Third, stage 3 LUTO, almost anhydramnios, hyperechogenic kidneys with cortical cyst and renal dysplasia. Biochemistry is not much favorable. Then vesicoamniotic stent here, if you recommend, it is serving just purpose to save the child from the early death because of pulmonary hypoplasia, but generally it doesn't work for the renal failure purpose. And the last stage is that everything is worst among these 3, and nothing is advisable, because unnecessarily it will lead to the fetal death as well as the adding maternal complications. So which is not indicated in this stage 4, where there is anhydramnios, severe renal dysplasia, and the urine chemistry is worst. So that finishes our discussion about this. I have to go a little faster, or otherwise we have to take question at this juncture, sir. Let me finish this scenario. This is something about the vesicostomy. Here the patient presented at the little later on 10th day with a high creatinine, and then one side reflux only was depicted, at least in the first MCU, with the severely trabecular bladder. You can see massive reflux, and rest patients was quite good. 7 days catheter serum creatinine, Nedis serum creatinine came to 2.3 USG, right? Loss of same differentiation on all those things. So, but here, this is high creatinine, and how to manage further. So evaluate by USG the degree of dilatation of ureter, specifically on the left side, which is better side. Right side kidney is already very poor, so our attention should be on the left side, as persistent significant dilatation is seen in the sonography even after the decompression with the feeding tube for 7 to 10 days. Our aim in this case is now for a low pressure bladder drainage, and hence the vesicostomy I plan in this patient. And there can be another option of a ureterostomy in this kind of patient. It depends on the choice of yours, but both can equally work. But vesicostomy, if you do a very careful vesicostomy, it is continues the recycling. Will take that area also. So what are the indication of vesicostomy in preterm infants, where the urethral caliber is very small and inadequate for safe introduction of instruments, rise in the serum creatinine despite successful catheterization and normal renal echogenicity, persistent hydroureteronephrosis despite bladder drainage, and persistent or recurrent UTI sepsis little later on. So these are the cases. You can see the massive reflux is there. Bladder is almost not getting filled because the most of the contrast is going into the kidneys, and these are very difficult cases to treat without having initial diversion in my practice. And if you if you try to avoid, they go on coming with the either sepsis or acidosis or electrolyte imbalance, and then they get repeated admissions. To avoid these repeated admissions, repeated morbidity, repeated cost, repeated involvement of the parents into the hospitals and hospitalizations, we have to give a good diversion. And best diversion is the Bloxham vasaectomy. Here it should be in the middle between these two points, that umbilicus and the pubic symphysis, almost 2 centimeter, and then try to identify the urachus, dissect it away, and then that only can, it's a landmark that you are sure that you are reaching to the dome only. So there you will dissect through the urachus little bit and the dome, and then open it up for reasonably of 1 centimeter, 1.5 centimeter, and then suture it, and then it will be working perfectly as a diversion. And there you can see in a follow-up, there is a good bladder recycling is there, right? You can see that bladder is filled almost completely till the bottom. And there you can see the significant reduction in the reflux dilatation. And in this patient, to not surprise, it is possible some reflux is seen also on the left side, right? So this is something about the vasaectomy and how it can be done. And this is something about the upper tract diversion. So when there is a persistent bilateral hydronephrosis with deteriorating renal function, nowadays we do very least commonly. Child had valve, this child had a valve fulguration at 2 months. At that time, serum creatinine was 1 milligram. Following catheter drainage, now at 24 months, recurrent febrile UTI has persistent bilateral hydronephrosis, and creatinine jumped to 2.5. What are the reasons for this of persistent and increasing hydro with sepsis, and how will you investigate this child? These are the questions posed to us, and the cause would be, now what are the causes we should keep in the mind is the PU valve with severely tortuous and dilated ureters. To start with, see here is this is the classical case when there is so much of tortuosity is there. If you just simply rely on the valve ablation and don't do anything in initial period, these are the child, they are going to create a problem. A valve bladder with poor compliance, there can be sometime residual valve or stricture formation, and then valve bladder with poor compliance, unstable contraction, recurrent infection, progressive renal deterioration secondary to the hyperfiltration injury, polyuria, hypertension, and rarely VUJ obstruction, which is generally otherwise functional. So what are the investigation? Again, we have to go through this all investigations, specifically sonography, look for the post-void residual urine, then repeat MCUG to see the residual valve, condition of bladder, reflux, urine analysis and culture for sepsis, fluid intake and urine output chart without failing in a toilet-trained children, and video aerodynamic study based on all these findings can be planned. And here in this patient, you can see that there is a persistent severe dilatation of the lower ureter on the left side and bilateral hydronephrosis. And then you can see in MCU, there is a significant reflux is there. In DMS scan, bilateral, there is a significant damage, or you can say a dysplastia, or you can say some scar element also. And then upper tract diversion, when to choose refractory urine tract infection, like in this case, a refractory valve bladder where anticholinergic and many CIC, nighttime drainage, all this tried, and still the upper tracts are worsening. Then it can be worsening of upper tract even after the vasaectomy. Very rarely people do vasaectomy, but still upper tract deteriorations are there because of massive tortuous ureters, which are thick wall. They are failed to coapt. They are failed to effectively peristalsis, and there can be retention of urine into the dilated ureters, and which will not allow, which will create the sepsis, which will not allow effective drainage of which will start giving the high residual urine and the whole cascade or vicious cycle of the valve bladder syndrome. So to break that completely, we have to think about the upper tract diversion and to ensure most optimal diversion and drainage of renal recoverability. So these are the possible advantages, may provide temporary preservation of renal function and addresses the repeated episodes of febrile UTI, reduces the hospitalization, and the injectable antibiotics may delay into time of dialysis, but no benefit is seen in long term respect to the rate of ESRD. Maybe I'm not sometime agree. Today we don't have the time to discuss, but we'll discuss that if we take a holistic care, which we are discussing and we are going to discuss, I think we can definitely reduce the rate of ESRD in this significant number of patients. The reason is that in most of the institutions, when I interacted, they said that we have fulgurated the valve. Patient came for a couple of times, two to three times, for a year or two, and thereafter we don't know, child must be doing well, and they are not coming. So this never can give us a definite idea why the patient has developed ESRD. Now, if you treat 100 patients and out of 190 patients are in your follow-up for 10 to 15 years, then only you can say that what exactly how nicely you tackle the rest of the years, subsequent years following ablation, and that will definitely help in reducing the ESRD incidence. So the disadvantage is that this why it doesn't help sometimes is that severe dysplasia, and if this creatine, nadir creatine or EGFR is very less, then it cannot be of help. Disadvantage, impairment of bladder dynamics, and undiversion requires additional procedure. So these are the couple of diversions. One is the pilostomy. In my training period, we were seeing in IKDRC, patients were coming with the bilateral infected hydronephrosis or pyonephrosis, and we were used to do pilostomy, and the patients were recovering really excellent. Maybe I don't have that long-term follow-up after leaving the institute, but so far, so I was there. I've seen a couple of patients recovering very well, and they are doing extremely well. I don't say that they are not going to develop anytime renal failure, but this was the procedure of choice at that time whenever they come with the pyonephrosis. Nowadays, we don't see that much of patients. Nowadays, whenever I need a diversion, my preference is the lower loop ureterostomy, which is very easy to do, and little bit of this kind of diversion can even continue a little bit of cycling. So these are the advantages and disadvantages. We're not going into detail, but my choice of the diversion is a pilostomy. If the infected hydronephrosis, very bad sepsis or pyonephrosis, and low loop ureterostomy. Now, few slides about the valve bladder. This term was coined by the Mitchell in year 1982, and this is term used to describe patients with the posterior valve associated with the bad effect on the bladder, which is known as a valve bladder syndrome. And 1/3 of the cases are likely to develop this. It can be how the patient present, suddenly they can have incontinence, those who are continent, or they remain incontinent, deterioration of renal function suddenly, and polyuria creates a problem. So valve bladder can present as a voiding dysfunction, incontinence, diurnal, daytime or nocturnal, recurrent UTI, and progressive renal deterioration. So here there is one case which I have depicted here. You can see that sonography at a certain age, persistent dilatation of the ureter on the left side and hydroureteronephrosis. There you can see the reflux is reduced in this patient, but still massive reflux, and this VORD kind of a case was there. There you can see the urodynamic was done, which is suggestive of low compliance and uninhibited contraction. So these are the cases which deteriorates over time, and then where you have to focus before we go on for further discussion is the renal tubular function in the PU valve patients. 50% of patients of PUV have impairment in concentrating ability and persistently high urinary flow rate regardless of fluid intake or state of hydration. And severe dehydration, electrolyte balance, we have discussed, ureteral dilatation, high resting vesicle pressure, which we are going to discuss, and fluid only at thirst, and that we will discuss. So this is the vicious cycle, which is very well described in 1982 by this Mitchell, and this is something like we can easily understand that when the child grow, almost 3 to 4 years, start going to the playhouse or to school, they try to hold the urine for a little longer, avoid voiding too frequently, and that will lead to the stretch on the bladder. Again, collagen filament changes, matrix deposition, then the bladder wall hypoxia, that will further lead to the bladder storage at unsafe pressure, and that pressure will migrate to the upper tracts, and then it will lead to the more and more renal tubular damage and glomerular damage because of pressure, tubular damage, and this will lead to the less concentration ability of the tubules, will lead to the polyuria due to the renal concentrating defect, and then attempt to void at the high voiding pressure, and urine stored in the and gradually the hydronephrotic kidney, which is storing a lot of urine, it comes down once the child completes the voiding, and it shows the pseudo high PVR or PVR, and collectively all together doesn't give bladder any rest time, any time which is completely at bladder is collapsed and at rest. So that is not there, and that will, the vicious cycle will continue, that again it will be stretch and hypoxia and deposition of matrix and this. So somewhere down the line we have to break this cycle, but most important thing you have to understand is the polyuria. We have to constantly think about the fluid intake and output chart of a 2 to 3 days in a patient who is a toilet trained. So hypertrophy, hyperplasia, ischemia, which we have discussed, collagen deposition, this leads to the storage, decreased compliance during the filling, uninhibited bladder contractions, and emptying issues are bladder emptying occurs with a high pressure, which can transmit to the kidney and the ureters. So in these patients, we have to do urodynamic evolution done to every child, right? Incontinence, sepsis, upper tract dilatation, deterioration, and changes can be unstable bladder unstable bladder because of uninhibited contraction, which we have seen in urodynamic, which I showed, low compliance, low capacity bladder, and later on, in later age, as vicious cycle continuously go on, because of these further matrix deposition, further stretching, and the hypoxia, there can be a myogenic failure where the bladder capacity starts increasing and they start overflowing incontinence and the failure of drainage of upper tracts and deteriorations and these all things. So long-term management of PU valve patient depends on the type of bladder dysfunction, which we have to keep in mind. So what should be our goal? The preserve renal function, compliant low pressure storage. Important is that we have to focus on the bladder, not on the ureter and the kidney of urine, by urodynamic evolution, anticholinergic medications, regular interval CIC, emptying means time voiding, maybe CIC, maybe nighttime voiding or nighttime catheter, avoidance of infection by prophylactic antibiotics, and socially accepted continence by this what I have mentioned already. At times we need to go for a surgery. Medical management includes the time voiding, right? Anticholinergics, which we have discussed the dose, clean intermittent catheterization to ensure the complete emptying, nighttime drainage as there is nocturnal polyuria, right? Which is very much helpful. All of these things you can read in the Campbell, that it gives a tremendous, these are the all randomized studies where significant benefits are seen in a large number of patients, antibiotic prophylaxis, and at times if the patient is not able to catheterize the urethra through the urethra because of elevated bladder neck or sensitive urethra, then we have to go for Mitrofanoff principle of appendicovasicostomy. And sometimes we need to address the BNO. I generally address the bladder neck hypertrophy with the drugs only. I have not attempted the Botox, which is a bit controversial still, and the BNI also having evidence on either side. So surgical management includes the bladder augmentation. We have talked about the indications, how it helps the enlarge the capacity, lowers the pressure, improves the incontinence, and preserves the kidney functions. And appendicovasicostomy sometimes along with the augmentation or without augmentation when the patient is not able to catheterize through the urethra. And nephrectomy, which is also a bit controversial area, which we will cover here. In this particular patient of VURD, we attempted for this kind of issue with the low compliance bladder with the uninhibited contraction. We go ahead with this augmentation. At that time, we plan ureterocystoplasty, knock down the kidney, and there you can see beautiful changes, or you can very important changes of dysplasia. Dysplasia is a diagnosis of histology, histopathology, and loss of normal tubules. You can see that cartilage islands are seen, hypertrophied dysplastic duct-like tubules, and immature glomeruli you can see. So, and what could be the reason for renal dysplasia? It can be a sustained pressure which is responsible for the damage. And another theory or associated theory can be a disorder organogenesis because of these abnormal insertion or of a Wolfram duct as well as the arising of the ureteric buds. So in this patient, ureterocystoplasty was done considering the low capacity, poor compliant, uninhibited contractions, upper tract deteriorations, and then the most important aspect is not the how big segment you are getting of ureter or ileum. It is how nicely you are bivalving the bladder. That is very important. If you don't bivalve bladder properly, any segment if you put, it will form a diverticulum sort of thing. So a complete bivalving of the bladder is the probably key of a success of any augmentation in specifically ureterocystoplasty. The advantage of ureterocystoplasty, I'm not going to go in detail. It is a native epithelium, native tissue, There won't be any mucus secretion, stone formations, as well as the any kind of other electrolyte imbalance like acidosis. If you use this intestinal segment in these patients, which is also some which we are forced to use at times, and there you have to keep the mind open for the acidosis. Something about the very interesting aspect. Again, Mitchell worked on this. He found out some bladder scoring based on the initial MCU, where you can say a bladder wall, if it is a smooth 0, mild trabeculation 1. So these are the scoring up to 4 based on the trabeculation and presence of diverticulum. Then the prostatic urethra, if it is normal, it is 0, dilated and elongated, it is 1. Bladder neck, if it is elevated, not elevated 0, elevated or hypertrophied 1. So total score is 6. So any score more than 4, you can predict that bladder is likely to behave bad, and in that case, you have to plan your follow-up, plan your investigations accordingly, because patient will get exhausted if you plan similar type of investigations in the follow-up, similar protocol in the follow-up. The patients who are doing well, they are going to get exhausted. So little bit of information. This is not sacrosanct. We can get a little bit of idea that how this patient is likely to behave, and in initial years, if it is like that, then we can plan accordingly the further follow-up and the investigations. So here you can see that this is a score 2 only. There is no much of the mild trabeculation only, no hypertrophy, dilated and elongated urethra, score 2. And this is how in the post 3-month or 6-month MCU, they are fared well. Again, this case we have already discussed. Here you can see also there is no bladder neck hypertrophy. It is elongated posterior urethra, grade 1 sort of trabeculations. Reflux in Mitchell's score, he is not considered any point to the reflux. So this is again, the score is 2 to 3. And there you can see 3 to 6 month MCU, there is excellent response. And based on this renal function is also preserved. You can plan your further. All patients need to be remain follow-up, but then you can design the follow-up individually based on these findings. And then something about the renal transplant in patients treated for PU-VAL. Then it is a prevalence of ESRD is 50%. Obstructive uropathy is second most reason. Safe bladder to receive the transplanted ureter, that is very important. We have discussed what the safe bladder is that. So urodynamic must before the transplant. And augmentation, there are two controversies. One is the augmentation, whether do prior or late or pre-transplant or post-transplant. But these are the things which we have to keep in mind, that it should be safe bladder to receive the transplant. Good capacity, safe bladder, how it defines capacity more than 300 cc, low end filling pressure, less than 30 centimeter of water, good flow rate, 18 to 25 ml per second, absence of uninhibited detrusor contraction, continence, renal replacement with, this is the finding. Also, CAPD is preferred than the hemodialysis. Maybe the Dr. Chawla and sir can explain, and the pre-transplant is ideal. And this is something about the, there was a lot of dogma before a couple of years that you augment or not augment before the transplant. But pre-transplant, if you augment before the you are augmenting before the immunosuppressant, less chance this is of UTI. But that argument is too young to take responsibility of CIC or manage the stoma and increase the risk of, they says because of that there can be increase of UTI. Now post-transplant, you can risking the graft loss by doing maybe sometimes you are avoiding augmentations and you are doing in the unsafe bladder. They says that it doesn't make much difference in outcome. Transplant in vasicostomy is also safe. So if your child is too young and it is already on a vasicostomy, you can carry on the transplant in a vasicostomy. Later on, at appropriate age, you can do augmentation or bladder closure with augmentation. And then at that time, Mitrophenol for CIC can be instituted and infection rates are less. So these are the couple of pictures, not going in detail. Last slide, that is favorable prognostic factors. The serum creatinine, which is less than 1 milligram per deciliter at 1 year. So nadir serum creatinine at 1 year, it is very important, even better indicator than at the 1 month. So nadir serum creatinine of 0.4 to 0.8, initial drainage after 4 to 5 days or 7 days to 1 month. If it is there, it is a good prognostic. Anything above 8.5 milligram, that is worst. Anything below 0.4 or you can say 0.5, it is almost excellent. And any between 0.4 to 0.8, it is you can say it's in a medium, it is in the middle path. Absence of UR or recurrent UTI, it is also a very controversial area, as we discussed that UR can be taken care very nicely. It all depends. See, all these things are changing and evolving, and it will go on evolving if we believe that the posterior urethral wall is a never-ending story. It is not just diagnosis and ablation. Preservation of the corticomedullary differentiation, so absence of dysplasia, renal parenchyma area. Something about any answer for this renal parenchyma area? What is renal parenchyma area? Shruti, you know? Amit, Aditya, there are so many Aditya, so I'm just randomly typed Aditya.
Amit Tiwari, Amit Sharma.
What is renal parenchyma area in presence of U wall?
Area other than the PCS, sir.
Okay, so area of the kidney, or you can kidney other than the PC system. So this is one of the criteria post MCU, post wall ablation at the 1 or 2 or 3 months when you do USG, and if you see the increase in the parenchymal area, that is a favorable finding, and anything 21.4 is worst against the 16 centimeter of this. There is a lot of work are going on, and this topic we can also pick up as a multi-centric study on. I invite many of the friends, senior as well as resident, to do some this kind of studies in our practice. Age at the diagnosis, again controversy. Some says that late diagnosis means it is a low variant of or a better variant of the wall, and that's why they do well. But they says that it's not true. If you pick up early, you can treat early, you can manage early, and then so there is a lot of evidence on either side. So we'll not discuss that much. Absence of bladder dysfunction, very important, or if there is a bladder dysfunction, we have to address that very vigorously. And genetic markers. These are the best prognostic factors. We just reverse. So this is the what could be the future directions. Early radiological diagnosis as early as possible. Biochemical markers and its easy availability. There are markers, but easy availability for earliest possible diagnosis and prognosis. Appropriate treatment before global changes takes place in utero, so close to the onset of the obstruction. If we can hit that area, we can have a better outcomes. And randomized study to determine ultimate outcomes of intrauterine interventions and reorientation on etiopathology, because now that concept is also coming up, that these folds are just fold that you are ablating, but you are still living with the rhabdosphincter spasm, and over time you have to address that also. So thank you very much once again for this opportunity. If I don't know, there is a couple of minutes are there still.
Anil,
it is over to you, Dr. Chawla.
Yeah, Anil,
I
just
hope
hold
that
on.
Thank you.
Yeah, no, I will come back to you. There are two things now. We have Professor Venugopal, who will be giving his valuable comments, and we have quiz also. I'll just take the opinion of Dr. Keshav, whether we run the quiz now and come back to you and Professor Venugopal. And Dr. Keshav?
No, 8:25, the quiz will be there. I think it's for 10 minutes. So it will be 8:35 by that time we finish. So if Professor Venugopal can make a quick comment, it would be fine, so that they can start the quiz at 8:25.
And if there are questions in the chat box, if
Anil,
you cannot
Anil,
take today, I will respond to them all individually, taking their contacts, email, and
while Dr. Venugopal is joining, there is a question. If there is a distal uterine stricture, is the reimplantation needed? Is it safe to undergo ureteric reimplantation for distal uterine stricture? What I understand is he wants to know about UV junction obstruction in the background of PU valve, whether we can.
Yeah. So I mentioned that in one of my slides that very very rarely there can be a real obstructed anatomically means obstructed ureter at the lower part, VUJ. But I have not seen, at least in my practice. Most of the time it is functional, and you have to take care of a bladder by these looking at the safe storage and the proper voiding and the emptying. So if you address, then most of the time I have not intervened for this kind of reason. But then you have to absolutely be sure about it. This requires a good diuretic study with the catheter in place to obviate the whole kind of a bladder dynamics, as well as any chance of reflux or any functional aspect. And then in that, if you are picking it up and you are working almost on every factors, rarely you can go ahead with this kind of a finding for reimplantation. Reimplantation in the highly thick trabeculated bladder is always issue. More failures are reported. So you have to be very extra cautious as well as expert to reimplant this kind of a ureter into the severely trabeculated and low compliant and low capacity bladders. But it should be very, very rare, very, very rare. Before that, at least you need to have an excellent diuretic scan with a catheter in place. Sir, go ahead.
To all the residents that I have sent a link to your WhatsApp for the quiz. You will have to click onto that link and that it will take you to that quiz part. You will have to enter your details and then the quiz will be there 30 seconds for each question. So it will not allow you after 30 seconds. I think most of you have the WhatsApp which I have sent. I have sent the link on the WhatsApp. So you have to go to the WhatsApp and then click onto that link and do the answering on that link.
There is a message from Rajendra. The WhatsApp link has been sent to the group. There is a MCH Urology Resident group and DNB Urology Resident group. The message is already put there. Those who don't have, those who are not the member of that group, you can ask your friends to forward you the message. Dr. Keshav?
Yeah. So this quiz is based on the PU-wall.
We'll wait for quiz to get over and then we'll ask, invite Professor Venugopal for his comments. Is it okay, sir?
That's all right. For me, it's not a problem.
Okay.
Excuse me.
Yes,
I don't know how to enter the quiz. I don't know how to enter the quiz.
Sir, you cannot, we have not sent it to you.
Sir, it is for residents, sir.
I know, but then what will happen in the intervening time? 10 minutes of time.
Sir, I am sending to you.
Them. You have to allow them.
I'll send it to you, sir.
No, don't send it to me. I can't go into too many areas. I'm fixed in one area. I'm happy with that.
Yes, sir.
Dr. Kesavamurthy, can I have a, if they are not getting distracted, we can have a little different issue talk.
Yeah.
I would like to share you that that as we discussed previously, from 15th of April to 15th of the May, if you allowed us USI ISU, then we would like to have a pediatric urology program. And I'm
no, I told you, no, I've given you the date of 2nd May, where you have to come.
We will not. Yes. 2nd May we will not be, Miss Sir. 2nd May.
2nd May is the date allotted for pediatric urology. So you will have to plan in such a way that you will finish your program by 2nd May.
2nd May. Okay, fine,
yeah.
Fine. Not beyond that. So we'll be planning in that way. So I'm sending you the mail for your consideration and the finalization, and thereafter we can roll that mail. And the plan is that we would like to come up with the same kind of a student mentor competition or say the presentations which is incorporating even the private setups, or you can say that corporate hospitals where there are juniors and the seniors are there, provided they should be member of Urological Society of India. And the second thing is that the theme is that how we do pediatric urology in our hospital or institute. And we will be inviting the teams from each zone, and there will be zonal competitions which will not be taking too much of time of all your stalwarts. Just if you permit us, we will be handling those kind of meetings with the help of 2 or 3 judges to judge the best team every day. If the teams are more, if the teams are less, then it can be finished in one day for one zone. And then at the end of all these zonal rounds, we will be having at least 5 or 6 teams to go into the final, and we'll request at that time to make that competition highlighted very much and to project on the broader this thing. And those out of those teams, those 6, 7 or 8, maybe suppose like last time we got a 32, this time we may got a 52. So we can have a couple of more teams reaching to the final, maybe 7 or 8, 10. Out of that, we will be judged 3 in the final round, and that 3 will be given opportunity to participate into the second global pediatric urology point of technique, or how we do pediatric urology at our hospital or institute competition, which we will finish by 1st or 2nd of the May. Depends on the availability of international participants and the speakers. So this is how we have planned it.
Okay. No, you can start early also, because if you want to finish by 2nd May, you can start in the first week of April itself,
Yes.
and then
Yes, sir.
finish it.
And I have to start sending the invitation from today only, start talking to the international friends, those who are wanting to, because they really enjoyed the participating in the first global meeting. 10 teams participate from across the all continents, and 15 presentations, 11 presentations from those teams, those countries. This time they are very enthusiastically asking for the second.
Anil, just excuse me. Navneet, you can put that on the chat box, the link on the chat box for people who have not got
it. It is there in the chat box, sir.
Oh, the residents are putting on the chat. I have not got the link. People who have not got the link on their WhatsApp, you can look into your chat box. There is a link on the chat box. You can type that, you will get into the chat link. You copy from the chat box and put it onto your, you paste it there and click that, you will get into that.
I was stuck in a couple of issues. That is the reason that I thought that we may take one more week to finish the period. But I got your point. We'll try to finish best way.
Because I've already allotted the webinar schedule to most of the subspecialties already.
But then you are allotting April to us, so we'll try to finish everything in April, right?
Yeah.
We'll be given 7 days from once we send the email to send their entries, and then subsequently 7 days we will give them to prepare, and then we will be having quick sessions, and then ultimately we will be in touch with the international peoples, and then at the end of day we'll be having a global meeting where we have to work on a couple of Saturdays or Sundays, and I will be in touch with you. Yeah. Dr. Chawla, you agree with this concept of student and mentor? I think we received a lot of feedback last year. Most of the institutions, they enjoyed participating. They competed within their institute itself, and they enjoyed competing with each other also in the same institute. That were the feedbacks. And not many, we got the personal mail messages that we enjoyed. So we are coming with a little bit separate, different kind of a topic, but the format will keep is a student, so we can have more people to participate, at least 2 persons in the team.
When to start the quiz program?
Sir, I think few minutes left now.
2 minutes, sir.
It's 20 questions are 10 minutes only, and we started at 26. I think by next 2 minutes we'll be done.
Amit, you have finished, I think. It seems you have finished. Gone very fast.
Hello. Okay.
Sir, my one of the suggestion is that if everyone follows that discipline of background noise, then multiple people can be participate in an interactive way. But they need to be disciplined for background noise, one, and second thing that immediately mute and unmute themselves once their name is come up. No? So that probably can make, because see, this generally only going on talking for 1 straight or 1 hour 15 minutes straight, maybe sometime more for the speaker as well as for the listeners. So if there is some questions, some interactions, then it gives you some good feedback that the residents have come with some preparations, and we can go to beyond certain level or to up to certain level in explaining them for particular the topic. Only hindrance is the discipline of working on the background noises and mute and unmute.
Yeah, we'll do that, Anil. We'll do
Yes, sir.
something.
But
about that,
yeah, today you supported that idea. Thank you very much, sir, for volunteering a couple of the residents.
Yeah. Meanwhile, there's a question, Dr. Anil, for you.
Sir.
When patient favor diversion, when vasocostomy, and when to do uterostomy? Can we go for uterostomy without prior vasocostomy? I think this is one of my favorite questions. Clear indications of vasocostomy versus upper tract diversion. Your answer to that.
Yes, sir. Sir, if there is a severely tortuous and dilated ureter, I saw the couple of patients where there is nothing is remained into the bladder in the MCU. Most of the things went up into the. These are the patients are less likely to respond quickly to the vasocostomy. So these are the patients. They were coming in the sepsis at one particular time, and we were compelled to do the upper tract diversions. But now these are the only patients in my practice where I think about the upper tract diversion. Because even if you do a good vasocostomy, sometimes these dilated thick wall ureters are not able to coapt, not able to propagate the urine properly. There is a lot of stasis of urine into the dilated PCs pelvical access system, and then that can give rise to the problem. I myself have never converted, never went from the vasocostomy, which has not responded, and upper tract diversion. Very few incidents of upper tract, but this is my criteria where generally, and later on, suppose the patient comes with the very bad, again, sepsis as well as upper tract deteriorations, which has happened at least one in my practice, that 2-year patient didn't come for follow-up and came in a very bad shape where absolutely again the severe dilatation tortuous system up and with very bad infections. Once we controlled that, we decided for the upper tract diversion. Rest of the cases, vasocostomy and vasocostomy, specifically in a preterm child where instrumentation is problem. Another thing is that later on, suppose if I've done a wall ablation and the patient is not doing according to the expectation, I still don't hesitate to go for the vasocostomy, because for vasocostomy, I never feel that the vasocostomy, if done properly, it produces any problem with the bladder recycling. I have never seen that kind of a problem in my practice, and that can be closed very well without much of. And the most important thing is that indication for vasocostomy is that not doing well the child means most of the time it is severe sepsis. With that, they go on getting admitted into the hospital. Lot of morbidity because of that repeated admission to the child, to the parents, to the family, cost and resources. If you do a good vasocostomy at that particular juncture, they will be definitely infection free. There will be a longer period. When we explain that after 8-10 months, we'll think about it. They themselves, they say that, okay, we are absolutely perfect, all right with this. Let the child grow till 2 to 3 or 4 years, and then we'll take a call. So these are though this is not clear-cut answer, but the only thing is that the very severely dilated tortuous ureter with some element of recurrent sepsis or persistent sepsis. For upper tract and for vasocostomy, I said that those who are not doing well with the initial ablation. So far,
Thanks.
infection, upper tract recovery.
And Dr. Keshav, shall we invite Professor Venugopal?
I think you can invite Professor Venugopal.
Yeah. So we have a teacher of teacher, Professor Venugopal with us, and I think he will be giving his valuable comments not only on what Dr. Anil has spoken, but from his vast experience. I think if we include all our experience of Valve together, and he is being on the other end, he will have far more experience than all of us together put together. So over to you, sir. Cordial invite to you for your comments, Professor Venugopal. Yes, sir.
Am I audible?
Yes, sir. You are audible, sir.
Audible.
Anil has given a very good exposition of the present day management of what we call PUV. Now, the whole thing is, he said in the first slide, is a lifetime treatment for that child. And you cannot just stop at one level and say that you have completed the treatment. I think the most important thing that we have to all understand is, when do we start treating and when do we stop thinking in terms of this child is not going to progress further. I think in my 50 years or more in urology, I have practiced pediatric urology predominantly as my first love in my entire spectrum of urological procedures that I have performed, or urological treatments I have given for many, many patients in my life. The most important thing that you have to understand in anything that you do is honesty and be sincere to your own patients. Unfortunately, often we do not follow this.
Please unmute yourself.
You complete it. Can I proceed?
Yes, sir. There was background noise. I wanted to stop there. Yes, sir. Please go ahead.
Oh. My 50 years of pediatric urology, my love has been on two areas. One is vesical reflux and other is post-viral wall. Both are intermingled to some extent. From the time I started pediatric urology in 1966 to 2021, I have changed my ideas and opinions on how to treat PVV several times. With each progress that occurs, it's almost like changing my ideas every decade. From starting with primary valve ablation, irrespective of what the pathology was, what the pathophysiology of the child was, we never knew all those things at that time. We just went and calculated the valve. And Anil showed a slide which reminded me of the procedure that I used to do during my early part in 60s and 70s. That was, since instruments are not available, we used to open the perineum and go in with the otoscope, and with the otoscope, with a plastic surgery hook the valve and snipe it away. And that was the treatment that we used to give for the patients. Unfortunately, because our understanding was so poor as a pathophysiologist is concerned, we lost several of these patients in the follow-up period. From that time, it progressed almost never-ending. Almost every decade it changed, and it became, we started understanding the pathophysiology of the disease better and better. Today, I can confidently say that though some of my patients are old, there are patients of mine who have lived long enough to father a child, and one such patient had a child who had a PUV. That was a long story that I had as far as urology, PUV is concerned. The most important aspect that Anil has emphasized is understanding the pathophysiology. If you understand the pathophysiology of the disease, then you can do a much better treatment as far as the patient is concerned. Understand, treat, go on thinking about it. What is that you want to do for the patient? How much can you do for the patient? It is enough that today, for example, Sham is not there with me, with whom I had lot of interactions on PUV and lot of fights on PUV, management of PUV. We had our own battles as our PUV is concerned. But remember, what it all amounted to was we both grew up together and learned how to manage PUV better and better. I need to emphasize a little too much on the importance of vesicoamniotic shunts, etc., which today, if you look at the literature, it is again been questioned as whether it will be done or not to be done, on whom it will be done. That has been highlighted by Anil. I don't know doubt about it. But does it really serve the purpose? What does Pluto study say? Pluto study was stopped not because of a father, mother, or a child. Pluto study was stopped because of religious reasons. The religious churches objected to the very fundamental fact that you are doing a study which has a lot of religious implications. As Catholics say, you cannot abort a child, or you cannot treat a child as a thing. And it's something which I don't want to go into the theoretical aspect of all these things. But whatever it is, it's stopped. So Pluto study, now today, for example, fetal cystoscopy he talked about. What is fetal cystoscopy? How many of us can do it? And if you do fetal cystoscopy, there are 3 types of urethra that you can come across. One is urethral stenosis, one is urethral atresia, one is, of course, PUV. Now, how much are we going to give attention to all these things? Now, these are all aspects that we have no idea even today what is what and how much are we going to treat. Now, you take an article that has come in 2020 in World Journal of Urology. What does it say? We still miss PUV if you don't do scopy. The MCU is not a foolproof investigation as a PUV is concerned. There are so many instances where you have to do scopy to detect PUV. But then, are we not going to overdiagnose? These are questions that I will ask. If you do a scopy in a neonate or in a child, you will find a lot of urethral folds in the posterior. Are they valves? They are not. Now, this segregation is important for us to understand what PUV is all about. Now, I can go on and on many, many aspects, which has been touched by Anil. I appreciate what the depth he has gone into, but at the same time, I may have to criticize him also because there are so many areas which unfortunately could not touch because of lack of time. He said the PUV is a lifelong mystery for the patient. I quote H.S. Watt. In all my talks when I finish, I quote H.S. Watt on one thing. PUV, where are the children in adults? This is what he thought at one time. Today, with our present day management and understanding of the disease, we are seeing children in adult life. And as I told you, I have a patient on whom I've treated, father and child, who had a PUV, son had a PUV. Now, these are all things that can happen. But at the same time, the incidence of transplantation after PUV has come down drastically. And that is because of our understanding of disease and the way we properly manage. Most important thing that now in all these things is, do not look at the bladder alone, look at the kidney also. A dysplastic kidney is a dysplastic kidney. That will never improve whatever you do on the bladder or whatever you do on the urethra. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir, for your words of wisdom, sir.
That was a wonderful disposition, sir. I remember Dr. H.S. Bhatt telling that you will be dealing with different types of fabric. It depends on what fabric that fellow has. That gives the longevity of that patient. If he has got a very bad renal dysplasia, all these things, that patient would not do well. And the patient has very good kidney and it's only not too much of obstruction and the fabric is good, these patients will long laster and they don't end up. That was the words he used to use. It depends on the fabric of that patient.
Thank you, Keshav. You put it rightly.
Yeah. Okay, before I invite Dr. Keshav and Dr. Rajiv Sood for their concluding remarks, let me congratulate Dr. Anil for an excellent talk. I think very comprehensively covered a very tough topic in a matter of 90 minutes. I think we started from the fetal period to neonate period to infancy and a grown-up child. I think if you have focused the lecture properly, he has very nicely covered right from fulguration to repeat fulguration to bladder neck incision to the syndrome of nocturnal overdistension of bladder and sensitive urethra, the vesicostomy, as well as Mitranoff procedure. He has covered augmentation. He has mentioned that this our reimplantation has no role, but still it is mentioned in the literature. He has covered VUR and uretrovesical obstruction also. He has covered very nicely the indications of urodynamics, very nicely and aptly described what is needed for you, the valve bladder syndrome, the Glassberg and Mitchell classification, all that you should be knowing also. He has very nicely covered. And he has gone right up to the transplant in the last slide. So you can see like the river flow nicely. He has covered from scenario 1 to the 6 scenario, covering every aspect of a posterior through valve. An excellent coverage of this, a very, very, very comprehensive lecture. Very difficult to cover in this 70 to 80 minutes. Very nice. I thoroughly enjoyed that, and so many points I learned from the Dr. Anil lecture also.
Sir, thank you very much. Sorry to interrupt you, but having that comment from a person like you, because you are always a joy to listen, and you are a master teacher. So I'm willing to be your student, and this is a best comment I received as a student from a master. Thank you, sir.
I request Dr. Keshamurthy and then Dr. Rajiv Sood for the concluding remarks.
Thank you, Dr. Anil, for your wonderful talk on PUV. It was, I've sat through the whole session. It was enriching to me also. And I think the residents would have benefited with that. I would request all the residents to send me a feedback on what would you want more, so that we keep this program going and improve upon doing something new which you want, if you want to improve the program. So please write to me on my email, or you can WhatsApp me in the WhatsApp group, so that we get the feedback of this program, so that we can improve upon this program. Thank you, Dr. Anil, and thanks, Dr. Venugopal, Professor Venugopal, for joining us. It was wonderful to have you in this session.
Dr. Rajiv.
Over to Dr. Rajiv Sood.
Dr. Rajiv.
Hello. So, thank you very much. Actually, can you hear me?
Yeah.
So it was a great program today, a new, some change, and Dr. Venugopal's presence has made a big difference in today's program. And it is a boon for all the residents, whoever has participated. And also it is a great initiative where more and more residents and more institutions will like to participate in future. This is a beginning, and I think this will continue. This is a great thought of Dr. Keshamurthy and also Dr. Arun Chawla. All the hard work which has gone, I'll give the credit, full credit to Dr. Arun Chawla for thinking and also giving so many suggestions, exchanging emails, and also now we are guided for the next programs in a better way. Now we are on the path of giving final shapes to all kind of programs, and also the overcrowding of the programs which was there has been reduced, and programs have been delegated. Even resident-oriented programs are also being delegated to different zones. So we are in a direction which will benefit USI, Indian School of Urology, and also the image of Indian urology globally. Residents are advised to be prepared for more better questions and also for interaction. It will open, they should open up in such meetings for more and more interaction, and they should volunteer now more frequently to participate, and participation will only help them to make the program successful and make the program useful for them. And therefore, everybody is to be congratulated today. We are thankful to Dr. Takwani, who has done great job, and also the great teaching lesson today, even for us. Thank you very much.
Thank you, Dr. Rajiv Sood. And I must thank the central office, Dr. Navneet, Mr. Navneet and Kiran, for giving us all the background help for this conduct of this program. Thank you, Dr. Chawla, for coordinating this session. Thank you, Dr. Anil.
Dr. Keshav, if you allow me 1 second. One question has come from Vikas Bise. I won't bother you. Last question. What is the oldest presentation of PUL you have seen? He wants to probably know at the oldest age at the presentation of 12 you have seen.
Oldest presentation. I have seen one patient of 11 a year. It is my oldest patient.
Dr. Venugopal, sir.
Hello?
Venugopal, yes, sir. Yes, sir. Please tell, sir.
My oldest patient was 42.
Yeah. Sir, I'll agree.
He presented the villa and happened to have gone to Britain, and when investigated, we found LPUV.
So I hope all the questions in the chat box are answered. We again greet each other and just wish good night to everybody. And get in the next class.
Sir, I would like to know from you or Kesumurthy sir that how I can retrieve these questions. These questions are there, which is already, because I think once the program is finished, questions will be disappear from the chat box. And anyone is having, so I can, if the questions are not answered, not to discourage this resident, I can send them individually the answer.
So all questions are answered. All questions are answered.
Okay, sir. Thank you.
So we have taken, rather, there was few questions which you were asking, and residents were replying in the chat box, and very correctly. There are few residents who were very correctly answering to your questions. But whatever doubts they have, we have answered them.
Okay.
Thanks.
Dr. Arun, on the question of this oldest presentation. Dr. Arun.
Yes, sir.
Yeah. On the question of the oldest presenting posterior urethral valve in the Dr. Ram Manohar Lohia Hospital and Sucheta Kriplani, which was the Lady Harding Medical College. These two colleges, we had presented together 10 cases between the age of 11 and 18 years, and all the experience and how they fared. So this is what I remember vaguely, and this all presentation is, and all the cases are with me in the computers. So this was already presented with the pediatric surgeon who handled that along with us. So this is my experience. I wanted that we can share. Many people in the remote areas, and because of reasons maybe more in India, they are ignored and they reach the older ages for presentation. And we had 10 patients, and this was presented 15 years back. So with this, I think this was the great evening, great program, and many such programs to come. Stay tuned with the Indian School of Urology, and we will be polishing our programs further with the help of you all and participation of residents. Thank you very much. Good night.
Thank you. Good night, everyone. Thank you.
Good night.